Hi everyone, thank you for coming. So today, Dr. Jerrod Brown is going to be presenting on anosognosia. I look at that topic with brain injury, you get injured to capacities, to abilities, and this one is the ability to sort of be aware of your condition and what is wrong with you, especially with brain injury problems. And I don't mean it in a judgmental way, but I know as I had brain injury, when I was 18 in 1999, just had a lot of things change in me, and I slowly was able to build awareness of those issues. So, injury to the awareness of it, it's a unique and difficult problem. So, Dr. Jerrod Brown, you can introduce yourself as well, and if anyone has any questions, feel free to ask, or you can put them in the chat, and I'll try to monitor the chat. Jared, take it away.
You bet.
Thank you.
Well, thanks, Dan. Can you see my slides and are they moving?
Yes, they are moving. They are. It looks like your slideshow. Yeah. So yeah.
Perfect. Well, thanks for having me back. This is the second presentation I've done for you and your group, and
Thank
today we're gonna take a deep dive into this topic of anosognosia. Really interesting topic. This can be very informal. Please interrupt me, folks, anytime if you want to interject. If I say anything you disagree with, interject. Let's talk about it. This, according to research, is the number one reason why people are not successful in treatment. And this term doesn't just apply to folks with a traumatic brain injury. It's very, very common among people with serious and persistent mental health issues, neurodegenerative disorders, substance use problems, the list goes on. The research out there right now, I've seen statistics all over the map. I've seen it anywhere from 20 to 50 or 60% of people with a brain injury may be dealing with some level of this. Here's my email address. Reach out if you have any questions. I've consulted on many cases involving a client that has this. Here's a copy of my brief professional biography. I am a professor. I do a lot of trainings for different groups around the country. I do quite a bit of publishing and research. I do a lot of consulting with different groups and consulting on lots of different cases. I've consulted on a variety of traumatic brain injury cases. I do a lot of work in the area of autism, fetal alcohol spectrum disorder, amongst a number of other topics. I have a number of different degrees related to the criminal justice system, neuroscience. I'm working on another degree right now to become a nutritionist at some point in the future. So I'm really starting to weave in integrative health into all the work I do, like nutrition, sleep, inflammation, the gut. And we'll talk a little bit about that stuff today. The consultation work I do, I've consulted on homicide cases, clinical cases, domestic violence, fire setting, all kinds of different topics. These are my main areas of focus. We're not going to be able to get to all these today. Of course, some of these we'll talk about in today's talk, but if you have any questions about any of these areas of study, just let me know as well. And these are some of my certifications and credentials. I have a number of different certifications in a variety of topics, including several related to the brain. I'm an executive function consultant. And then these are my graduate certificates. And one of my graduate certificates is in traumatic brain injury. I have a couple in neuroscience and neuropsychology. So we're going to talk a lot of neuroscience today as well. So as we get into this topic, anosognosia, I first want to just do a recap. I'm not going to take a deep dive into what is a brain injury because I'm assuming we all know what that is. But if you look at the research, again, this can vary from person to person, but these are some of the most common consequences associated with sustaining a traumatic brain injury. Now we know there's mild, moderate, and severe cases. Most of the consultation work I've done have involved individuals that have had mild traumatic brain injuries, but don't let that fool you because mild kinds of injuries to the brain the person can still sustain a number of long-term effects, particularly if they've had multiple mild head injuries over and over and over again at various points in their life. Some of the most common causes would be when we see multiple head injuries over a long period of time. What pops in my mind? Contact sports, domestic violence, child abuse situations, people involved in the criminal justice system, individuals that may engage in a lot of high risk behaviors, including substance misuse. And again, brain injuries can happen from all kinds of things, a car accident, a slip and fall, sporting events, things of that nature. But as you look here, behavioral control problems, memory issues, a number of physical health issues. We all know this. I just want to remind us, just in case you're new to this discussion. This will come up several times today, why I'm just showing you these things. And then when we look at the cognitive deficits, we all know that most people who have sustained a traumatic brain injury will be dealing with some level of executive function impairment. When you hear me talk about executive function today, that is the boss of the brain. That is the CEO of the brain. It kind of guides day-to-day behavior. It relates to problem solving, decision making, how we manage money, how do we drive a car, how do we interact with people. Executive function impairments, very, very common. Attention issues, very common. Information processing deficits, basically what that would be is if you're asking somebody a question who has information processing deficits, they may take extra time to respond to that question. I can think of a case I consulted on a few years ago where the client had profound information processing deficits. And you literally ask this person a question, it may take them 30 to 45 seconds to respond to that. This will all come into play when we talk about screening and intervention strategies in a few minutes. And if you look at the bottom of this slide, self-awareness issues, we all know what that is. Anosognosia is partially rooted in self-awareness deficits. So when you are learning about anosognosia, it's imperative to understand the literature related to self-awareness problems. It's equally important to understand the topic of metacognition. Metacognition is thinking about thinking, knowing about knowing. A lot of these slides could be multiple hours of training. So if I go too fast, just interrupt me anytime if you want me to go back, go a little bit deeper into any of these things. So when we think of anosognosia, again, it's not just going to be an issue among somebody that has a brain injury. It's very common among other kinds of disabilities, deficits, disorders as well. But at the core of anosognosia is that individual's lack of ability to really acknowledge, identify, label, understand that they have a disability. So, for example, if somebody with a brain injury has anosognosia, they will not legitimately recognize that they have a brain injury. So, why is that important to be aware of? Well, if that client who has a brain injury has anosognosia and they don't believe they have a brain injury, what do you think is going to happen? They're probably not going to go to treatment. Why would they go to treatment if they don't think there's anything going on with them? If they are required to take medications, they're probably not going to stay medication compliant. If their family is consistently telling them, hey, you have a disability, you need to take your time, you need to slow down, it's going to create more family conflict. To name a few, I'll talk about many, many consequences associated with this today. If you look at this research literature, and there's all kinds of studies on anosognosia within the context of a variety of different disorders. Some of the studies talk about it as a neurological term. Some articles call it its own syndrome. Some articles call it a disorder. I really fall under this camp. It's more of a clinical phenomenon. It's multifactorial in nature. People with this are going to have lack of self-awareness. even in the face of compelling evidence. So, for example, the client with a brain injury doesn't believe they have a brain injury, but they're being presented with compelling evidence from their medical doctor. Maybe it's a brain scan. Maybe it's family members that can confirm that that person did sustain a brain injury. They are going to be very indifferent to that, maybe in some cases. And it's very important to consider this too. If somebody is dealing with anosognosia and if they come off as very indifferent, that could look like apathy. And in some cases, apathy can look a lot like depression. We'll talk about that today as well. Dan, I'm going to park the brakes for a minute just to let this digest and see if we have any thoughts so far before we get a little deeper in the weeds.
Any questions?
What's this? The way I get real forthgoing and really ready to go, and then all of a sudden it just fizzles out, and I can't do anything. I have all this insight, and then all of a sudden it just falls apart, and I can't do anything. I just have to sit down and you know can't go, can't get up and go to what I want to do. Say, for instance, let's say I want to go over to the computer. Okay, I think of what I want to do over the computer, and then I'll sit there on the couch and I won't get it done. And
Yeah,
it,
do you think it could be a million things going on? Could it be mental fatigue?
oh
Could
yeah,
it be motivation deficits sometimes where you feel really motivated, but then the motivation just is out the window, it's gone.
hmm
Yeah, when those things come up, and this is what the research says on that, look through an executive function lens. It's likely partially rooted in executive function impairments. And I'm going to show you a bunch of stuff about executive function today.
Okay.
Everybody deals with executive function impairments on some level under the wrong circumstances. But unfortunately, people with a brain injury are going to be more prone to it. I deal with executive function impairments if, like, maybe I didn't sleep the night before and we're just so tired. That is so normal. If someone's dealing with a ton of stress, that can impact it. If somebody skips a meal and maybe there's some nutritional deficiencies, that can impact it. I don't have a brain injury. So if someone had a brain injury and had those things going on, likely it's going to impact them even more severely. So we'll talk about some basic strategies maybe to consider that might help with that as well.
All right, thank you.
Yeah, yeah. Thank you for sharing that. Please, more the better, folks.
I know, Julie, that you had talked about in the past the coma state of being just completely unable to function. I think with brain injury, the fatigue can come on really strong and really fast, especially when we're trying to do the things that are the hardest, the things that are what we injured. It leads to that basically you can't function at a certain point, which is really hard to deal with. Um,
Yeah, and that coma state takes over,
yes, it's completely
and
exhausting. Yeah,
this leaves me, yeah,
yeah. I was gonna say something about I hear people talk about metacognition and you grow up thinking and you know about your thinking, but with brain injury, you have to apply the meta to the thing that got injured, which is a lot weirder. For example, with processing speed, I remember my therapist talking about processing speed with me, but I'm like, I can feel that the processing isn't working. It's all these little details of thinking that I lost and spent many years regaining. And I was very focused on it. It's that focus that is like meta. I'm applying it to something that I had to make sense of it for months before I could wrap my mind around it. And so metacognition is what unbrain injured people know about, but the part that gets injured it's not on your list. It's like new to your list. So I think of this condition, anosognosia, as injury to that meta part. And I'm glad I guess I'm glad I didn't injure that part, but I injured a bunch of other things. So I see that lens, I apply that lens to the other things that can get injured in other people. if that makes sense.
So when we think about this, Dan,
Yeah,
within the context of metacognition, if someone had true anosognosia, that is probably going to impact their metacognition where they can't think about their own reduced error awareness.
right.
It sounds like you, Dan, can think about that. Maybe it's more difficult, but by you being able to think about that, that's not anosognosia. So let's break this down a little bit more so we know where we're coming from, because this is a confusing term. Deficits in self-awareness. So if somebody has a really hard time going inward and having good introspection, good self-awareness, that's a component of this.
Mhm.
In the research literature, I disagree with this. You'll find some studies that say anosognosia is denial. It's not denial. I'm going to show you the difference between denial and anosognosia in a few minutes. Medication noncompliance, as I kind of alluded before, is a huge risk factor for this because, again, if, for example, I've consulted on cases where the person's had schizophrenia, that's very common to have anosognosia. If the person doesn't believe they have schizophrenia and they're being pressured to take meds for schizophrenia, they're probably not going to take their meds because they don't believe they have schizophrenia. And reduced error awareness. This is where we need to be aware that vulnerability and victimization go up. For some people with true anosognosia, they may have reduced error awareness where they have a hard time learning from previous mistakes and they make the same mistakes over and over and over and over again. Another component of this. We'll keep breaking it down until it sticks. This is a very small snapshot of the research literature on this, but there are studies about anosognosia for having no awareness of motor skill problems. So people that have mobility issues, if they have anosognosia, they're going to believe they don't have any mobility issues. There are studies that talk about this within the context of visual impairments. And what we're kind of talking about today is more the third one, the cognitive brain-based executive function metacognition aspects of this. Okay, so denial versus anosognosia. Denial, self-protection. Anosognosia, organic lack of insight. They look very similar, but anosognosia is the product of the brain injury. Denial could be maybe someone no longer can work after the brain injury, but they tell everybody, yeah, I'm going back to work in a week. And even though maybe inside they know they're not, they're doing that for self-protection because they want to protect maybe self-esteem. Maybe they're dealing with high levels of shame, but on the surface, it can look very, very similar. If this doesn't make sense, you want me to go a little bit deeper into this, let me know, but this is the best way I think to really break apart these two.
Yeah, that's kind of the point that I was making of the ability to think about what is wrong with me, why doesn't this work, and then slowly through trial and error, and the errors are over months and years, having that ability to make sense of it, that piece can get injured in a person. And I had denial across the board, across all of this stuff. So it's a vulnerability issue. Okay, so yeah, I think it's good to break this down and um just to because people don't even know that this kind of problem can exist, which is really makes it harder when the other people around you don't believe you and don't have the lens to view it by. So yeah, break it down as much as we can.
Yeah, remember, 20 to maybe 60% of folks with brain injuries, according to the research, will be dealing with anosognosia on some level. And like everything, it's a spectrum. You can probably have very, very severe cases, and you can have more mild as well, and everything in between. Why am I really talking about metacognition and executive function today? Well, because of this. If somebody has anosognosia, that should instantly alert us that there's something not working properly in our frontal lobes. We all know what the frontal lobes are: decision making, problem solving, reasoning, and a million other things. That's kind of the hub too of why we're talking about metacognition, executive function. When we think of the prefrontal cortex, when it's working properly, these things work very well. When the prefrontal cortex is not working properly and we have more executive function impairments, we might have more difficulty regulating our thinking, controlling our behaviors and actions and moods, problems with emotional management. It can really get in the way of personality expression. There's lots of studies that talk about in the TBI literature that a high percentage of people after a traumatic brain injury may actually have personality changes. That's another variable here where you hear from family members, my loved one after the brain injury is just not the same person as they were before the brain injury. Again, different for everybody, of course. Poor decision making over and over and over again is an indication of prefrontal cortex issues. And I consult in a lot of cases where social behavioral problems are at play. On the extreme end, could be stalking cases, inappropriate sexual behavior. On the other end of the spectrum, maybe it's someone that has just some friendship making deficits and they have a hard time starting a conversation, ending a conversation, using language in that social context. If you know people that struggle in any of those areas, that's also an indication maybe the prefrontal cortex is not working at optimal levels. Dan, I see we have a hand raised.
Yeah, can the frontal lobe dysfunction be repaired so that it's not a deficit?
I think it can always get better. It depends on the severity of the injury. Maybe there is structural damage. I do a lot of work in the area of fetal alcohol spectrum disorder. So that's a topic that talks about this a lot where there was prenatal alcohol exposure in utero. Can it be repaired? Probably not, but there are things we can do to make it a lot better. And I'll show you when we get toward the intervention section, what do we do to make it better? I'll give some really practical tips about that. But right now, just basic things. What can we do to make our brains work better? Get better sleep, eat healthier, exercise, build social support, improve gut health functioning, reduce chronic inflammation in our body. A lot of things I'll show you in a few minutes and stuff. So
Okay, well, thank you.
anosognosia, yeah, you're welcome. Lack of awareness, lack of insight. This topic, again, is studied within the context of a lot of different conditions. Some of the more common conditions where this comes up in is going to be schizophrenia, related disorders. Almost everybody with Alzheimer's disease has some level of anosognosia. And again, maybe 20 to 60% of people with brain injuries have some level of this going on. When we think about poor insight in general, poor insight is a facet of anosognosia. What can happen? Number one reason why people are not successful in treatment, according to research. This could be drug and alcohol treatment, mental health treatment. It could be physical rehabilitation. If that person has anosognosia related to a physical disability, they're probably not going to want to be there because they believe there's nothing wrong. Research also shows that someone has a drug and alcohol problem and they're dealing with this, they're much more likely to relapse. In some cases, it could be a risk factor for violent behavior toward others or oneself as well. From a clinical lens, so when we start thinking about clinical, think of like mental health treatment, if any of you are mental health professionals, social workers, psychologists, but this can apply to case managers as well. The research is very clear that folks who work in these kinds of settings are going to be encountering people with anosognosia all the time. However, how often are mental health providers educated about this topic? Rarely, in my experience. How many drug and alcohol treatment programs have advanced training in anosognosia? Not too many that I'm aware of. TBI, again, it comes up in this literature frequently. And again, when we think about impaired awareness, it pairs it with metacognition. I can't stress enough, if you really want to learn about this topic, learn as much as you can about metacognition as well. Dan, maybe we could do a talk on metacognition in the future. It's such a foundational topic, in my opinion.
Yeah, I'd be happy to. And I actually have a question. So you had that short list of the different realms of anos. I say anosognosia in my head, so I say, but it doesn't matter.
Yeah, no, that's fine.
Yeah. So with the body stuff, with the visual stuff, with
Yeah.
the cognitive. So do you see when people have injured this, or when people have this problem of lack of awareness, does it apply equally to all those internal realms? Or do you notice that like, oh, they can find it for their body, but not for this? Or is it, I don't know.
I believe you'll find some research that says it's just universal for everything. I don't think that's the human brain is too complex. There's probably going to be some areas maybe they have good awareness on, in other areas, not so much on. Maybe they have a brain injury. They have no awareness about the brain injury, but they have pretty good awareness that they feel depressed. That could be an example. Or maybe someone completely has denial that they have any mental health problems going on, but they have awareness that maybe they have a slight alcohol problem. So I don't think it's going to be universal. Every case, every situation, in my opinion, should be individualized because we're all different. Genetics, family experiences, the type of injury one's had to their brain can differ. The region of the brain that got impacted can definitely differ as well. So I'm a big fan of functional, holistic, integrative, individualized kinds of approaches, looking at each person individually.
Yeah, and that makes sense with it not being necessarily universal to all parts of what a person has to deal with. The other thing I was going to say is that yes, as soon as you have other people involved, especially when they don't even have this issue on their list, it becomes very strange because I remember slowly building awareness of certain of my problems, and then when I try to share that with other people, including clinicians, they like deny it or give some other explanation. And if I had injured my ability to have the awareness, their lack of support would make it even that much more harder. Instead, it just became a weird fight or like a I don't know, needing to prove myself to them because I was like, you don't understand, I really am dealing with this. So it would be great to help educate the clinicians more.
They have stuff on here. If we have clinicians here, what can you do about this? I'll show you some stuff. Hopefully, we're starting to realize this is an important topic and we need to be aware of. If you're still on the fence, take a look at this. If you have a client you're working with who has a brain injury and stealing anosognosia, it impacts self-esteem. It impacts their self-efficacy, their self-worth. These are all things that can get in the way of goal planning and goal achievement. Other things to consider, looking at this holistically, negative consequences on functional outcomes. What in the heavens does that mean? Think of adaptive functioning. Think of independent living skills. If this person has a brain injury and is dealing with these kinds of things and they live independently, what are some functional things that could happen? Problems with money management, problems with cooking, problems using transportation, problems communicating their needs to their family members or loved ones, their healthcare providers. Without a doubt, it adds added stress to the whole family system. So it's equally important, not only for professionals to learn about this, but to teach family members about this. Because if family members don't understand this topic, a lot of times they get more frustrated, more irritated, and it leads to more conflict. Other things to be aware of, again, it could be that lack of awareness that I even have a brain-based deficit. It could lead to impaired ability to monitor one's own behavior, practically speaking. This could be an individual where they're not trying to do this, but maybe they're a close talker or they intrude in other people's spaces. That's not their intent. On the surface, it could look like harassment, or it could even get to the point of stalking, where that person, that's not their intent to do that to another individual, but if they lack complete awareness, that can lead to breakdowns in interpersonal communication skills that then adversely impacts loved ones, coworkers, classmates, neighbors, whoever. This next section, just in case some of you are interested in the criminal justice, forensic, legal arenas, the research also says if you work in these settings, you are working with people that are dealing with this all the time. And because of that, get more training, become more aware on this, seek out consultation, review the research literature. This has significant legal implications. It has significant implications for mental health treatment. Why does it have legal implications? Well, if a defendant has a brain injury and is dealing with anosognosia, what are some things that could happen? False confessions, wrongful imprisonment, wrongful alibi, over confessing to something that maybe they had a small part in, but they take a larger role. Significant implications. If we have any attorneys here or paralegals or anyone working in that realm, very, very important to be aware of. And if we have any probation, parole officers here, people working in jails, anything like that. This is what the research says in general for people leaving a jail or prison setting. Look at all these potential factors to take into account here. Let's say the person does have a brain injury, and we know from the research, half the people or more in jail or prison do have a brain injury. This is where I do most of my work in the area of brain injuries is related to the forensic legal realm. If you tack on anosognosia to this, more times than not, that person who's involved in the criminal justice system is not going to be successful on probation or parole and will likely violate and have to go back to court in the revolving door of just continuing to be involved in the criminal justice system over and over again. Dan, go ahead.
Hey, Jared, just to play
Yeah,
the devil's advocate,
yep, of
I
course.
am related with a lot of lawyers in my family and my friends. So how can you prove or show or somehow exemplify? Because that list you had, one can argue applies to everyone that gets out of prison or out of the legal system. So how do you know they're not lying? How do you know they're not making it up? How do you know that this lack of awareness ability is really there? Or how can you show it to others? Can
Yeah,
you?
this applies to everybody, of course,
Yeah,
but
yeah,
just if you tack on the anosognosia, look how much harder this could be. How do we prove it?
yeah.
Go to trainings. I'm offering more trainings on this topic. Be aware of the red flag indicators. If people really want to get more in-depth training on this, there's a number of different screening and assessment tools out there that professionals can use to screen for this. So it's not just you're on your own and you have to just kind of guess, does that person have it? There's a number of screening tools out there that are validated and supported in science where you could start using with your clients if you had the proper training and credentials, of course.
That's great. Yeah. I think that with screening and show that it's evidence based, that at least that puts it on their radar. And I think the key is for them to believe us or at least take us at our word. But can I also read a question that was in the chat?
Yeah, please.
This person wrote, so or I have a moderate TBI and my daughter had a severe TBI. It was in the same accident. For a year I said my daughter was in an accident. I never mentioned me. I forgot I was in it, but I got a job to prove I was still worthy. Can that be anosognosia?
No, thank you for sharing that. I'm sorry that you guys were involved in that. And I don't know, that wouldn't be anosognosia. Anosognosia would be if someone got the brain injury and absolutely has no belief that they have any deficits caused by that brain injury. It's not denial again, but it's that organic lack of insight that I don't have a brain injury. I can do all the same things I've done before, even though maybe my medical doctor's saying I can't work anymore or I need to take it easy. But the person thinks everybody's lying to them, and that person has absolutely no awareness or insight into their deficit. That's anosognosia. Keep them coming. More questions, the better, folks. Another variable to consider from a legal lens is if the individual has a guardian or is under conservatorship, or if you're a mental health provider and you are giving, obviously talking about informed consent, if that client has anosognosia, that could be very tricky for that person to understand those processes. Extra precautions may need to be taken. This next section is kind of all about like red flag indicators, different screening things we want to be aware of. And again, I'm just showing you study after study. I'll send Dan my slides. Dan, feel free to share them with whoever you'd like. At the bottom of each of my slides is my full citation. Multiple studies again say increased training, awareness, education. This particular article talks about psychiatrists, hospitals, and clinical staff are oftentimes not well trained or equipped to really work with patients with poor insight, anosognosia. So again, it doesn't matter if you're in the criminal justice arena, mental health, medical arenas, you probably haven't had a lot of training in this topic, even though you work with clients all the time who are dealing with this. Rehabilitation. This is what the research says in a nutshell. This is not an all-encompassing list. But if somebody goes to any kind of rehab center, this could apply to mental health treatment. What are the main factors that get in the way of successful rehabilitation? It could be for mental health, substance misuse, physical health kinds of factors, anosognosia, top of the list. Dan, you mentioned alexithymia earlier. That is a huge, huge barrier for successful rehabilitation. A lot of these are overlapping. Hopefully, you're seeing overlaps now. Executive function impairments. If the individual is chronically sleep deprived, dealing with a lot of daytime fatigue, maybe they're dealing with chronic pain issues. Any one of these factors can get in the way of successful rehabilitation. And most of the time, in my experience, when consulting on cases, the client is not dealing with one of these factors. They're usually dealing with a combination. So the more of these things going on with one particular individual, the more tricky it gets, unless that rehab specialist understands and takes these things into account during the treatment planning, goal planning process. Any questions on anything on this particular slide you want me to go a little bit deeper into, or
I think the interaction of brain injury problems is a huge problem, and I've never heard anyone talk about it. Yeah, they're associated, but they're also super interconnected. So yeah, thanks.
you bet. So this slide is rehabilitation in general.
I have a question. Can you turn back that page? Yeah, my executive functioning problems, that's located in the front of the brain, am I correct?
Yeah, there's other parts of the brain too that play a role, but we always want to be aware of the frontal lobes, the prefrontal cortex when we study that topic.
Okay, because that's where one of the places I was hit the hardest in my brain, in my head.
Oh.
And ever since then I've had sleep issues also and chronic fatigue.
Sleep issues, very, very common among people with a brain injury. I do a lot of work in the area of sleep. I'm a certified sleep coach. I'm not giving medical advice today, but what some of the research indicates about a brain injury is we need to be aware that in some cases, the head trauma may have impacted the parts of the brain related to our sleep-wake cycle. So we really want to be aware of circadian rhythms.
Yeah.
Working with a healthcare provider who understands not only general sleep problems like insomnia and things like that, but also circadian rhythm alignment. That's going to be very, very important to be aware of as well.
I went to a doctor, and he said that I had sleep apnea.
Yep, that's
And,
very common too.
and then I said, no, this isn't working because I don't think that's what I have. I was arguing with him about it, you know. And so I started getting more sleep. I started getting, like 8 to 15 hours of sleep a night. And I was better from the apnea type situation where, you can nod off anywhere. And so I just wanted to let you know about that too, because misdiagnosis is common also in that area, I think.
Yeah, sleep apnea is an interesting topic. I talked a lot about that, and it seems like every other person I know nowadays has sleep apnea, but with traumatic brain injury, a couple things could be going on. Let's say if someone does have sleep apnea and they have a brain injury, weight could be a factor, but another factor would be central sleep apnea. Did parts of the brain, that neural circuitry, get damaged that relates to kind of respiration? Did someone sustain a head injury and also break their nose or have some bones in their face get misaligned? That can play a role as well. So really working with somebody that truly understands these kind of things would be so important.
Okay, well, I'm gonna look a little bit further then, because I think I have a more serious injury than has been noted.
Yeah, I guess I can't comment on that, but
I
finding
no,
good healthcare providers who will really listen and understand and dig deeper and look at all the moving parts, I think that's the way to go.
yes, yes, sir.
What you're describing sounds to me like you can have both because I've seen billboards on sleep apnea and advertising everywhere. That's a common thing. But I had a flip circadian rhythm, and no one believed me, and no one even understood what I was talking about. And I basically slowly shifted it over like 2 decades. But I never met anyone to talk about that until I met some people with brain injury in the support groups. And the other sleep issues, like I mean, brain injury people talk about it, but the clinicians don't. So you can have the apnea plus the brain injury things, and then it accumulates and only makes things worse. But they don't always know about certain problems. That's why I'm glad Jared's talking about that. So
Yeah, well, and thank you, Jared, because you did help it with answering my part of my question.
Absolutely, yes. When we think of sleep too, I mean, sleep hygiene practices would be something you'd want to look into. There are providers out there who have advanced training in cognitive behavioral therapy for insomnia. That's a great modality. There's a million things. Nutritional factors play a role, mold, sleep positioning, how much light is coming into the room, temperature in the room. Sleep's complex. And that's like the number one intervention, in my opinion, for healing after a brain injury. You mentioned earlier too, how do we improve executive function? Well, one of the best things we can do is get a handle on our sleep. Sleep is
No.
number one to health, in my opinion. And then obviously nutrition, exercise, and a number of other things. But if someone doesn't sleep well day in and day out, that is a threat to their health, including their brain health.
Jared, there's
Yeah.
two questions in the
Uh,
chat. Can I read to you?
Yeah, yeah.
Okay. The first one is so it reads, these clinicians behave as if they already know everything that they need to know and are not open to learning anything more. It is exceedingly difficult to educate these clinicians. They do not want to hear what you want to explain to them. And so that's the end of the question. And I can just say that, yeah, that's been my experience as well. It, how do you deal with that, or what can be done about that?
Good. I'm not giving any medical advice here, but if you have a clinician that's like that, and maybe you need to switch clinicians, not all clinicians are like that. I find somebody that's curious, who's going to do a lot of listening and is open to collaborating with other people. If somebody thinks they have it figured out, that's probably, in my opinion, that's not the person I would go with. You would have to make that decision. And a lot of times when we're talking, look at all these moving parts we're talking about. Not one professional is an expert in all these topics. It's usually piecing it together. So maybe you have a primary care doctor. Maybe on top of that, you have a sleep specialist, a nutritionist. Maybe you're working with a mental health provider. It gets tricky. I've consulted on cases where there's like 8 to 10 providers involved. The last thing you want to do is have providers work in silos who never collaborate with one another. The best thing you can do is make sure everyone understands everybody's role. You're coming to the table, you're revisiting things, looking at things that are working versus not working. And I'm a big fan of holistic integrative approaches, digging deeper, not just looking at the leaf or the branch of the problem, but getting at the root. And a lot of times that requires professionals to go deeper and not be surfacey in their evaluations, their questions. And sometimes they may not know the answer, and that's okay. Maybe they need to seek out more guidance and consultation on some of these things.
Yeah, thank you for sharing that. I would say that I also experienced what that person's question was, and it became a siloing at best, and there was no executive hub for the brain injury help that I got, to the point that after 3 years, I basically gave up on them because, at best, in the silo, the person who knows about that silo only helps you with that. And that happened with two clinicians, but that's out of like, I'd say 2 dozen. I just gave up on them. Becomes a very frustrating experience. There's one more question. Would you say that someone with TBI who can no longer smell has a physical contributor to sleep issues?
The smell component, olfactory kinds of things, is going to be more elevated among some individuals with a brain injury. Can that impact sleep? Sure. But on the flip side of that, there's literature out there, and I actually talk about this in some of my FASD trainings. You might see on the flip side of that, somebody has more olfactory sensitivity where they're more sensitive to cologne, perfume, incense. That's a sensory issue. So you might do well working with a sensory processing specialist, and that can really get in the way of sleep. And if someone loses their sense of smell too, that could be a safety consideration. Think about if there's a fire in one's home or they have a gas stove and the gas is running and they can't smell it anymore. That could be a safety consideration. So taking some safety precautions there too and finding maybe some adaptive kinds of technology that can help compensate for those kind of things would be helpful. Dan, for sake of time, I better burn rubber through a few of these. So you remember the previous slide I showed you about rehabilitation issues? This slide here is more meant toward mental health providers. So if we have any therapists, counselors, social workers, the research also says anosognosia is at the top of the list that can get in the way of therapeutic engagement. Therapist, anyone doing any kind of counseling would do well learning about all these topics here. Because if you don't know about these topics, for example, if you don't recognize or realize this term in your clients, you may misjudge them, misread them, and that is a major threat to the therapeutic engagement, which can lead to breakdowns in the goal planning process. Folks, I just threw this in here. This is not TBI. This is for serious and persistent mental health issues, but I wanted to just throw this in here because most of the cases I've consulted on where the person's had a brain injury, they're also dealing with a co-occurring mental health issue, depression, anxiety, could be bipolar disorder. Lots and lots of research on being aware of this topic within the context when working with people with serious mental health challenges. In the research literature as well, I just wanted to point this out. If somebody has true anosognosia, they might be at an increased risk of admission to an acute care facility. If anybody works in crisis stabilization kinds of centers, you are probably coming into contact with even higher numbers of people with anosognosia. And if you work in jail or prison or forensic state settings, you are coming in contact with people with anosognosia all the time, according to the research. Dan, here's some of the screening tools that are out there that kind of ties into your question. It is completely outside the scope of today's talk to get into the weeds on these. This is not an all-encompassing list, but these would be some of the tools that providers would, if they want to develop an expertise in, start being aware of these tools. Read up on the literature, seek out some trainings. Screening questions. So maybe it's a lawyer, a probation officer, a case manager. They don't have the training in the mental health arena per se, or the credentials. These are just red flag indicators that might be able to be incorporated into any intake session. Does the client have a diminished ability to understand the nature of their disability? Red flag indicator. Does the client have a reduced understanding that they even have a disability? Does the client fail to acknowledge their disability? Does the client not really feel distressed about their disability, even though everybody else around them does? If the client struggles in these areas, I'm not saying it's anosognosia per se, but these are red flag indicators that you want to dig deeper. Executive function is impacted typically. Memory problems need to be aware of. And insight. Insight, I would use interchangeably here with metacognition. Other things to be aware of, just some red flag indicators. By no means am I saying if somebody has these things going on, it means anosognosia. But the more of these cognitive-based problems somebody is dealing with, it's imperative to at least consider the possibility that maybe anosognosia is co-occurring with some of these things. Cognition, we talked a lot about the brain today, the prefrontal cortex, executive function. These are some of the basic components to be aware of that fall under the umbrella of cognition. People with brain injuries, a lot of times, may have some difficulty in these areas. Maybe not all these areas, because again, everybody's different. But the more of these areas that are impacted, the greater likelihood they may need some extra support services or interventions to help compensate for some of these areas. What do we do about it again? This kind of ties into this. These are the critical steps required for long-term success. Every single one of these is related to executive function. Providers, healthcare providers, mental health workers, in-home workers, the more they can understand these topics and incorporate that into their goal plan, the more likely that person's going to be successful with their treatment goals. Some general questions to consider about executive function. Again, we're not teaching people how to assess this, but the more of these going on with an individual, the light bulb should go on. Maybe I need to work with a professional who understands executive function, somebody that can target these areas, maybe do some brain-based training. Maybe there's some in-home skills workers the person could work with and really target some of these areas. Again, wish we had more time to focus on all these today, but they'll be in the slides Dan can share with you guys. Metacognition, anosognosia, again, here's a good article if you want to look at the interconnectedness of this. Red flag indicators of metacognitive deficits, thinking about thinking, knowing about knowing deficits. These are other red flag indicators that you may be working with somebody that is dealing with some level of metacognitive impairments. The more an individual is dealing with some of these deficits, again, the light bulb should be turned on. I probably need to work with somebody who understands metacognition. Theory of mind, Dan, another topic we might want to look at sometime in the future. Theory of mind deficits relates to perspective taking. It's a component of empathy, and it is very, very common among people with a brain injury. If somebody has theory of mind deficits, it likely leads to breakdowns in interpersonal communication where the person can come off very stoic or rigid or self-centered where that's not their intent. But if they have deficits in theory of mind, another variable to consider in this big complex puzzle. Theory of mind relates to understanding what other people want, what other people know, and what other people believe. If somebody struggles with these, that is a good indication they're dealing with some level of theory of mind deficits. Everybody with autism has theory of mind deficits. Not everyone with a brain injury has theory of mind deficits, but a high percentage do. People with schizophrenia are more likely to deal with this. Almost everyone with fetal alcohol spectrum disorder will be dealing with this. If the person has struggle with negotiating, collaborating, resolving conflict effectively, the research also shows it may be a theory of mind deficit on top of other things going on. Theory of mind is poor perspective taking. This is what it can look like practically speaking when you're interacting with somebody. So if the person consistently has these interactions when working with other people, let's say the person has a brain injury, is dealing with this, and they go to therapy, but that therapist has no clue about the term theory of mind. That therapist may jump to the conclusion that person is selfish, doesn't want to be here, and maybe end services when in fact it might be rooted in a brain-based impairment, when in fact that person is not trying to be selfish, even though their injury is making them present that way. Dan, I'm going to rush through this and then I can stick around as long as we need. So what do we do about it? Tips, strategies, solutions. Today's a good starting point. We learn the term, learn about the research. It's very, very important to know that anosognosia, the person is not doing it on purpose. It's a product of their disability. Unawareness of an illness, disability, deficit, or symptom. This, when I see this, when I give talks on this and consult, this helps me have a lot of compassion for people who have this. Because if somebody has true anosognosia, their inner world might be rooted in fear, confusion, more paranoia. They're suspicious of other people. Of course, they're going to be that way because if they believe they have nothing going on with them, but they're being forced to go to the hospital or be in some treatment program, I'd be terrified. I'd be paranoid. Anger control problems. They can present as very stubborn. Take a step back, pause, reflect. Don't jump to conclusions when you see this in a client or somebody. We need to educate family members. Very, very important for family members to be aware of this topic. These are some basic strategies family members can use to help build resilience within that family system. These are general strategies we can all use if you're a professional, family member. Increase your awareness. Focus on symptoms rather than the illness. Person-centered approaches. I'd focus more on building the strong relationship than trying to convince the person they have a brain injury. Maybe get that out of the equation. Okay, the person doesn't believe they have brain injury. Let's not even go there. Let's just focus on the relationship. Focus on trust building. Do a lot of listening, less talking, more listening. Try to avoid arguments, confrontations, power struggles. We need to adjust our expectations, encourage open communication, and provide helpful feedback. Focus on empowerment, hopeful thinking, focusing on the future, using positive language. Try not to convince the person they have a disability. I know as much as we want to, we're trained in that. Maybe that's not helpful right now. Avoid any power approaches. If you're a professional, collaboration rather than power over. Avoid coming off as the expert to the client. Less talking, more listening. And some of the research says if you're professional, consider diagnosing the symptom. Note the symptoms rather than the disorder. Other important reminders, just all positive things I think we can use with anybody. Capitalize on strengths. Trauma-informed care, motivational interviewing. Find professionals who understand executive function metacognition. These are just basic strategies I think can be very helpful for all people we work with. Here's my email again. Reach out. Again, I threw a lot at you. This is multiple hours of content in a short amount of time, but I'll stick around, Dan, answer as many questions as we have.
Thank you, Jerrod, and thank you for offering this bird's eye view of all these aspects or this large overview because that's exactly what I was hoping to achieve here. And yeah, a lot of stuff you brought up. I want to ask questions, but does anyone else have any other questions, any other comments?
Can you email people the information?
Yeah, I'll get the slides and I can just send it out to everyone registered here. I have your email.
Oh, that'd be
Yeah,
wonderful because
yeah. So,
there's some terms in there that I feel like I'm just half of that stuff, you know.
mhm, mhm.
So okay, thank you, Dan.
Yeah, and I think about half of that stuff. For each brain injured person, all the stuff on those lists may not necessarily apply. Um, it's kind of ironic to say though that digging into what are your issues though can be the issue itself with anosognosia. So it's kind of a it becomes a difficult problem to deal with. But that list with the fear and anger, I think that most brain injured people have to deal with that as well. So it's good for other people to realize that that introspective part can also be injured and we're afraid and angry and stuck and not able to do what we thought we should do before the injury. So yeah, it's a really big mix of problems.
Absolutely. Thank you, Dan, for having me back. And thank you, everyone. I appreciate your time. And you have my email. Reach out anytime. Take care, everyone.
Okay,
Yes.
thank you, Jared.
You're welcome.
Yeah,
Thank
thank you
you.
very much.